Okay, so this is thinly related to orthopedics because in like orthopedics, thinking like fractures and things like that, we don't have a lot of drugs for that, right? We can treat pain though, and so you see a lot of pain management being involved with orthopedics, and so this is kind of the best opportunity to talk a lot about pain management. So we're going to cover all of our opioids here. We're talking about more about NSAIDs, acetaminophen, talk about neuropathic pain. We're going to kind of get it all in this section, and we'll relate it back a little bit. We'll talk about things like DVTs and venous thromboembolism a little bit later on, since that is a common thing you worry about, especially in orthopedic surgery. After or post-op, you worry a lot about clot formation. So we'll talk about that at the end here. So anyway, pain management. Who likes to have pain? There's probably some masochists out there. And I don't know. You don't want to tell us. That's fine. That's fine. Anywho, it's a very common complaint. Obviously, people present all the time, urgent care clinics, ERs, etc., saying they have pain. And so this is a big issue because, again, proper management of this is going to be huge. And how can you tell if someone's in pain? You read their face. I mean, look, heart rate, blood pressure can be useful. How you know they're not just lying to you? Hmm? Okay, you can elicit tenderness. That's one thing. Some people are really good at faking it, you know. I have patients who, or I've seen patients who will come in complaining of a kidney stone, and then when they go to do the urinalysis, they will actually kind of prick their finger in order to put blood in the urine sample to fake having it, right? They'll do a lot of things, and so it's very difficult to get an objective sense of pain, right? Because again, if you're having someone try to tell you about their pain, how do you normally have them express it? On a scale of 1 to 10, what's your pain right now? And they say, oh, I'm like at a 9. You're like, you're at a 9 right now? Like, think about 10 being the worst pain ever. Like, I'm chopping your arm off with a rusty spoon. Yeah, I'm a 9 right now. Okay, you're just sitting there just totally fine. Okay, whatever. But you have to take the patient's word for it in a lot of cases. So, pain assessment is going to be huge. We'll talk about that briefly here in regards, but mainly we're going to focus on different ways we can try to kind of get optimal pain management for these patients. And honestly, there's a lot of barriers to this. So a lot of patients may be very stoic and may not want to get treatment for their pain because they worry about things like addiction, right? Or fear of adverse effects due to some of the medications. I hear a lot of people say, I don't want any opioids. I don't want to get hooked on that stuff. Stuff kills people. And they don't get good pain management, right? And that's usually what leads to a lot of issues with optimal pain management is if you're not getting treated appropriately, that's when you can see self-medication. That's where you can see using things like alcohol to help with this, and you can run into other issues down the line. So we'll look at some ways to get around that. Also, there's a lot of healthcare provider related issues. So again, if you're worried about getting your patient hooked on something and addicted, that can be an issue. Especially in the ERs and things like that, people tend to get a little cynical. I would never get that way, but some people do. Is that whatever, they're just lying. They don't really have pain. And so that may be a barrier to getting actual good pain management. And then also fear of governmental regulation, right? So Florida used to be like the first stop on the OxyContin Express. Anyone know what the OxyContin Express is? See some people are like, what is that? That is basically we would have a lot of these operations where these docs would write huge amounts of opioids. They would have pharmacies that these patients would go to where they would fill them kind of just without really kind of giving a second thought to it. And so they'd have bus loads of people, and West Virginia was particularly bad for this. They'd have bus loads of people come from West Virginia, drive all the way down to Florida, get these scripts for hundreds and hundreds of Percocets and Oxycontins, etc., and then drive them back up and then disperse them out. So that was a big deal, right? Because this is a huge place where a lot of prescription opioids are being used. And in fact, what's interesting is that since the government has come in and cracked down on a lot of prescription opioid, a lot of these pill mills and things like that, as they called them, now we're starting to see a resurgence of other type of opioids. Anyone know what we're starting to see more resurgence of? Heroin. Heroin's starting to become a big deal. I honestly can't count how many times I've seen heroin in at least when I was in fellowship, and this is downtown Jacksonville, we never really saw heroin. A lot of it was just prescription opioids because it was so easy to get. And so nowadays we're starting to see a lot more heroin starting to come about. We're starting to see heroin being laced with things like fentanyl, other issues like that. So you're starting to see some shifts here. But Florida's a big issue with as far as pain management goes because we had so many kind of bad apples that were kind of spoiling it for everyone else. So again, there's a fear of kind of governmental regulation on that, and we're getting more stringent on that stuff. So remember, anyone know what hydrocodone, acetaminophen, or Lortab used to be classified as from a controlled substance standpoint? It used to be a 3, but now, anyone know what it is now? It's a 2, right? So now it's more strictly regulated. You can't give refills on it. You can't, you can't have all the other regulations we kind of talked about regarding C2s. You can't do more than 90 days worth. You can't do all these things, and so it's become much more stringent and hard to get a hold of. That's actually become an issue too, because from a peds standpoint, we have a lot of post-op kids that are coming out. We write, because kids, can they always take tablets? Not usually. They can take liquids, and so there is a liquid formulation of hydrocodone and acetaminophen. But if I call a pharmacy, and a lot of places don't carry it because it's not used that often unless you're dealing with the surgery kids. If I call up the pharmacy and say, hey, do you have this stuff in stock? This is hydrocodone and acetaminophen liquid. What are they going to tell you? Do you think? They're going to tell you no. Why? They don't get robbed, right? Because that's the big concern, is that someone says, oh yeah, I have like 1,000 Percocet that are here. I have 1,000 Oxycontin 80s. Why don't you come on by? You might get robbed, right? That's the concern. And so a lot of places will not tell you. So you'd have these parents who have kids that are just out of surgery, they're in pain, and say, hey, do you have this stuff? And every pharmacy is like, no, we don't have it. We don't have it. We don't have it. And so it was difficult for them to actually get the main medication for their kids. So again, it's kind of tragic, but it's an issue we run into. Did I tell you my story of getting robbed? This is my second day of interning as a pharmacy intern. So I was, the first summer, as I was a first year pharmacy school, and the first summer there, I said, all right, I'm gonna go get a job. I'm gonna intern during the summertime. Let's go to CVS. That'll be fun. Second day working there, I get held up at knife point. He said, where's your Lortab? And it's back there. You go take all of it, please. It was like me, a pharmacy intern, and the pharmacist, and both of them were like maybe 90 pounds sopping wet, and I was like the biggest guy there. I was just like, just take it, just right there, go for it. And then like the pharmacist, I ran after the guy to like try to get his license plate, and I was just like, what are you doing? You're gonna get killed. But he got license plate, got the guy, and it turned out he left an infant at home by itself. Don't do this. Very sad, but justice was served. And I said, never again will I work retail. I'm going to go for hospital now. I said, if I get robbed at the hospital, then I'll definitely know pharmacies. Just not for me. So, anywho, so yeah, lots of issues with that. Lots of nefarious people who are utilizing some of these pain management medications. But right, so there's a lot of systemic issues. Kind of mentioned that. So lack of especially trained pain management specialists. Because again, can anyone just be a pain management specialist? Not really. Like, you need some specialized training in a lot of that, and they get really kind of good at a lot of the finesse to it. For instance, like my wife, she did her second year residency at the VA. Only did pain management. Like, that was specific, a whole year just doing pain management for these vets. And a lot of them have addiction issues. A lot of them have a lot of psychosocial issues related to their pain. And so it was, it takes sometimes a lot of training to get really good at handling these kind of patients. And then there can be issues like reimbursement and whatnot. And then we'll look at some of these kind of alternative techniques that can be difficult to kind of get a payment for. But, so again, pain is very subjective. Have you guys covered like pain management anywhere else already? Probably like here and there, but probably nothing like specific. So we'll talk about it here. But if you can come up with an objective way to measure someone's pain, you'll be a gazillionaire. Because right now we don't have anything, right? You can do things like try to elicit, tenderness. Patients can fake that, right? Things like blood pressure and heart rate, they're good to look at. Good to see that it's up. But for some patients with chronic pain issues, they may not have that. They may have been blunted a long time ago. And so you may have patients who are seriously at an 8 out of 10, and they're just kind of sitting there comfortably, but they've been dealing with it for years, and it's just like that's them now, right? So very subjective. A lot of times you have to take the patient at their word, and that may not always be the best case depending on your patient, right? And so we say pain is kind of whatever the patient says it is, but we'll have some clarifiers here. We'll look at some different types of pain, and we'll see how the therapy differs between those. Right. So big thing to note, are we dealing with acute pain or chronic pain? Sometimes you can have acute on chronic. And then as far as chronic goes, obviously there's a kind of persistent, kind of all the time sort of pain. They may have intermittent pain where, things will aggravate the pain at certain times of the day or certain activities. And so this will be important to kind of getting our regimens under control, because we'll have both controlled release preparations, long-acting forms of pain medication, and then short-acting forms. And it's important to know when to use each one, right? Because the better you can get that under control, the better off the patient's going to be from a pain management standpoint and lowering the total amount of dose they need. And then, we'll focus more on the somatic versus neuropathic versus visceral pain. Usually the somatic and visceral pain tends to get treated similarly, even though the etiology may be a little different, but the neuropathic pain we're going to see has a different management strategy to it. We're going to find different medications that are used to help manage that for these patients. So we kind of alluded to that already with a lot of our antidepressants, namely things like our SNRIs and our TCAs, but we'll talk about those here kind of in more detail. Remember any anti-epileptics we use for neuropathic pain? Gabapentin's a big one. See that used a lot for like fibromyalgia. Pregabalin, kind of the cousin to gabapentin. Those are the big ones. You may see like topiramate occasionally. I don't see it too often, but gabapentin is probably one of the big ones. Anyway, so again, just kind of comparing these. This is pretty straightforward, I imagine, for most of you guys. But acute pain obviously lasting hours to weeks versus chronic pain patients can be indefinite for a lot of them. A lot of times, with the acute pain, you can kind of link it back to an acute issue that is managed, whether it be surgery, trauma, whatever it happens to be, and it's pretty predictable for the most case. You're going to see that the primary treatment for these patients will be analgesic. So if you have a short-term acute pain issue, I can give you short-term management for that, and then you're kind of done. Versus the chronic pain is going to be much more difficult. It's going to be multimodal as far as treatment goes. We need to focus on several kind of points of attack, because again, you just don't want to say, well, just give them more opioids, because that's not really going to be the best answer for a lot of patients. You need to try to attack it from a different perspective in order to help kind of manage that a little bit better, right? So again, more drugs is not always the best answer for these patients. Keeps me in business, but it's not good for the patients. Let's not do that, right? Looking at the nociceptive pain versus neuropathic pain, how did you kind of differ between the two? If you had to describe it to a patient, how do they feel? Yeah, a lot of paresthesias, a lot of shooting pains, a lot of tingling, burning, those sort of sensations. And again, these are caused by that nerve damage and will be treated differently, as we'll see, than specifically some of this more kind of nociceptive, somatic sort of pains, the visceral pain. This is going to be more kind of a sharp, dull, aching, throbbing sort of pain. It'll be managed more traditionally, as you might imagine, with things like opioids, NSAIDs, and whatnot. But the neuropathic pain, because the etiology is different, we're going to use different medications for that. So obviously the cost is going to be huge. We have billions and billions of dollars each year that are being sunk into pain management. But again, if we can get someone more able-bodied, more able to kind of perform normal functions, that's going to be better for them, because again, with a lot of these pain patients, you're losing a lot of productivity, disability, a lot of lost days at work. So it's a very, very costly sort of thing. And obviously quality of life is going to be huge. There's a lot of anxiety and depression that goes along with chronic pain. So oftentimes you're kind of deal with the psychosocial issues in addition to what the actual pain issues are going to be. So the best thing to note here is that optimal pain management is going to depend on getting their assessment of pain done as accurately as possible. And so my wife can tell you all kinds of good stories about this. But you'd have patients who get very linked into like their number, like my pain is a 6, and it's always going to be a 6 from these really chronic old vets. And you'd be like, okay, well, I'm going to go change your medications around. And you come back the next day and like, how do you feel? And it's like, oh, I feel great. I feel way better than I did yesterday. Like, what's your pain? A 6, still a 6, because that's their number, right? Sometimes they'll get really invested in this sort of thing. And assessment can be pretty difficult, right? And you guys have already had plenty of training on how to kind of have patients describe the pain to you to get kind of a better assessment, kind of location, the onset, the duration, what makes it better, what makes it worse, etc. One of the things I kind of want to focus on, one is the characteristics. So obviously kind of this will give you some differentiation between, is it more of a neuropathic sort of thing? Is it more somatic, visceral sort of pain? That can be very useful. And then the intensity of the pain is really the thing I kind of want to focus on here, because it needs to be more specific to your patient. So for instance, like how do you ask a kid what their pain level is? Can you go, hey Jimmy, you're only 2, but on a scale of 0 to 10, what's your pain right now? 10 being the worst pain you've ever experienced. And he's like, well, I stubbed my toe yesterday. I guess that was the worst I've ever experienced. I'm only 2. How would you have him describe it to you? Yeah, you give him the FACES scale, right? The Wong-Baker FACES scale we can use for that. I think I have it on the next scale here, but that can be one of the big things, is to try to get it down to their level. Or in some cases, if you have like older patients who have cognitive impairment, again, they may not be able to utilize a typical sort of 0 to 10 kind of pain scale. Maybe it's something like kind of a different FACES scale. Some have used like a thermometer sort of scale. I think I have a picture of that next. Anyone ever have any worked with a visual analog scale, 10 centimeter scale? Anyone know how to use this? Basically tell the patient, on the scale, kind of point your finger at where you think your pain is right now. The nice thing about this is you can use, and then you measure basically how many centimeters it was. And you can, the next time you go back, patients, okay, how's your pain now? After you got some medication, they can, again, point their finger. It's more difficult for them to kind of hone in on what number they were specifically. They're not shooting for a certain number. They don't really know where they're putting their finger. They can probably put it in this general area, but you may be able to get a little bit more objective sort of measurement out of them if you can do that, and kind of compare and contrast it as time goes on. Again, no scale is going to be perfect for these patients. It's all going to depend on kind of what their what kind of their intentions are, and kind of what their certain kind of their thought processes and their beliefs and things like that. I don't remember the comedian that it was, but there's a guy, he's a comedian, he's going into the ER because he's having a really bad abdominal pain, and he's in a big ER, and all these different patients. The nurse is going around asking, okay, what's your pain scale, and seeing what medications the guys are getting. He's like, well, I need to figure out what number I'm going to tell them, because I want to tell them like a 10, because then they're not going to think I'm serious, and they won't give me anything. But if I tell them too low, then they won't give me something good enough. So what do I tell them? And he decided like an 8. 8's the perfect number, and just to get the medication that he wanted to actually treat his pain. He wasn't like drug seeking or anything like that, but it's very funny. Apparently, you guys thought so as well. Look it up; it's funny. Anyway, here's an example for pediatrics. Use like a Wong-Baker faces scale. So it's like, how would if you had to give your face a pain or your pain a face, what would it look like? That can be useful. Sometimes like thermometers. Most people nowadays have probably never seen a thermometer like this, but older patients certainly have. And able to give you a better idea of kind of what their pain is utilizing this. Based on temperature, sort of. So obviously, look at modifying factors here. One of the big things I would have you guys focus on is what works for them. Like, what did they try previously? If they have tried all the NSAIDs under the sun and none of them works for them, what's the point of giving them an NSAID again, right? And so getting an idea of what they respond well to. Some people respond to opioids really poorly, and that's just not a good drug for them. So getting an idea of what they've tried is going to be important. Also, especially if they're coming in for an acute pain issue, see what they've already taken that day, because that may preclude you from using certain medications. So for instance, someone comes in, they've already, they broke their arm and they took 800 of ibuprofen right before they came to the ER. I'm probably not going to give them another dose of an NSAID. I might switch over to something else, right? So ask those kind of questions. Make sure you get the right, find out what doses they're taking, because they may be treating themselves inappropriately, either too low a dose or too high a dose, and you want to be able to capture that to educate them and to possibly give supplemental doses. So I've seen this before, like where parents will come in with their kids who've had some pain issue, and they gave them the wrong dose of Tylenol because they just didn't know any better, and gave them too low a dose. And we can give them a supplemental dose, kind of get them up to where they should be, right? So sometimes we'll do that. So again, unless you ask the questions, you won't really know. And obviously, impact on function, behavior, mental status is important to assess as well. So again, looking at their assessment, medication history is going to be super important here as well. Kind of see if any of the medications they're on may be exacerbating their pain. That could be one issue you can kind of figure out and elucidate from the history. Want to look at labs, certainly, so we can look at organ function. Some of these things are not going to be good if you have hepatic disease, if you have renal disease, so you can avoid some of those medications for those patients. And then look at a history of substance abuse. Obviously, if they have a history of this, then you may not want to give them an opioid. Maybe you want to give them something, a non-controlled substance, to manage their pain. So there's things to consider. Let's see. Right. So basically, when you're dealing with kind of moderate, severe chronic pain, you're going to find that they kind of have a persistent amount of pain kind of throughout the day, right? And they have these kind of peaks and valleys that occur throughout the day. Usually, like some sort of activity or movement or something like that will help to exacerbate these pains. And so we call this kind of breakthrough pain that occurs here when it kind of gets worse than normal for them. What you're going to find is that when we're dealing with chronic pain issues, you want to make sure you have kind of basal pain control, kind of baseline pain control kind of done throughout the day. So if you kind of look at this line here, this is where you'd have, say, like a long-acting medication to be able to kind of manage most of their pain throughout the day. But then when they have breakthrough, this is where you're going to need kind of more of an as-needed sort of medication. So this is where you might find where a patient is on, say, OxyContin, which is a long-acting form of oxycodone, say twice a day. They're on that for their kind of chronic baseline pain, and then you're going to find they may need an immediate release product, say oxycodone 5 milligrams, as needed for breakthrough pain. And that's totally valid for them to be on both of those at the same time, because you need to manage these breakthrough pain. However, if I didn't have this breakthrough pain really being well controlled, how do you think the patient is going to respond to that? They'd probably try to self-medicate, right? They may take more of their controlled release preparation. And again, the more opioids you get on board, the more likely you are to see dependence and addiction develop. And we'll talk more about specifically those in just a few minutes here. But again, keep in mind, you need to have basal control of their pain, and they need to do something about their breakthrough pain. This is also important, like in the post-op setting as well, where we'll have patients who will be come out of surgery. They'll need some sort of basal amount of pain control for them, and then they'll have kind of as-needed doses on top of that to help control that. You guys ever heard like a PCA, patient-controlled analgesia? It's a little button you can tap to give yourself the morphine. And we'll talk about that a little bit later on, but that's basically one way we can do that, where the patient controls it themselves. We'll set them a basal rate of drug they get kind of every hour, and then they can give themselves extra doses. Okay, so we'll get more into detail on that a little bit later. Of course, I froze up my stuff again. These pictures, what's the matter with them? Any questions so far? Okay. So when dealing with these approaches, I know Professor Quinones has mentioned this at least at one of the last PD labs, but I guess heard of the WHO ladder. Again, this is not British rock. This is the World Health Organization. Another great joke. Anywho, sometimes you'll treat based on etiology. So, for instance, migraines, we have a certain treatment algorithm that we'll use for those because we know what the etiology is there. We know cerebral vasospasm is the main component to that. We can give drugs to manage that. A lot of times, if you're dealing with more kind of nonspecific pain, you can utilize this kind of WHO ladder sort of approach here. And so, basically, this is a stepwise approach. Pretty simple, but it's important to try to follow this whenever you can. So, for instance, with the step 1, this is going to be kind of the most mild pain. This is going to be the most mild medications that we can give. What type of things do you think would fit into step 1? NSAIDs would be good, especially oral NSAIDs. Tylenol will be decent in this option, in this stage as well. Again, these are typically non-opioid drugs, right? These are very kind of minor drugs, good for kind of mild to moderate aches and pains, things like that. Try to start with this if you can, right? They had worse pain, you can move on to a stepwise approach. If I gave them ibuprofen and Tylenol and that was not handling it, then I could do a stepwise approach and go into something next. So then this is where you may utilize opioids, right? So use usually a combination of things. Opioids are going to be good for this kind of moderate pain. This is more good for like oral medications, right? Oral medications that are not going to really have to pack the punch on an IV agent would, but still decent for handling that more moderate pain, moderate severe. And then if that's still not working, then you can step up to this kind of third line. Or step 3 here, where you can utilize like IV medications. They're going to work very quickly, very potent opioids, in addition to these other adjuvant agents here. So, what do you think the benefit of this is, following this type of approach? Yeah, maybe I can reduce the amount of people getting opioids. That's going to be beneficial, right? Because again, we know there's side effects associated with that. We know there's issues with opioids. All right, good. So, do you always have to start at step 1? If someone just had coming in with their arm chopped off, maybe step 1's not good for them. Like, here's some Tylenol. Let me know how the arm's doing. Come back. If they find it, maybe we can. So I don't know. No, you can start off on step 3 if you need to, right? So they come in, they can obviously displace fracture. Like, let's give you some meds, right? Let's get you started. Give you something to really kind of knock that pain down, and then you can start to worry about other adjuvant medications. So again, you don't always have to start at step 1, but again, you can always give more drugs. You cannot necessarily take them back once they're in. Okay, so you don't want to show your whole hand there. You always can kind of try to use that stepwise approach where appropriate. In a lot of cases, you'll see this, especially like in post-op orders that are being written. And we focus on, we try to do this in at Nemours. We have our order set up to where you'll actually have 3 levels of medication set up for patients. That way, the nurse goes in and say, "Hey, what's your pain on a scale 1 to 10?" And the patient answers, and they will know which medication to give based on that scale. So, for instance, they will have, say, acetaminophen for a pain scale out of 1 to 3, and then we'll have, say, oral oxycodone for a pain scale of 4 to 7. And then for 8 to 10, they'll get IV morphine, right? So that way they follow that stepwise approach. So that way they're not having to blast a kid with morphine every single time he, has a little, has a pain scale out of 2. It has different steps there, and then we can direct the nurses on which one to give. Because otherwise, the nurse has 3 orders on the profile, and they're all just says PRN pain. The nurse can then decide which one she wants to give, and that's really independent practice, and that's not allowed, especially by Joint Commission. That's kind of outside their scope, and so that's why we have to build in things like these pain scales, so that way they can say, okay, if it's a 2, I can go ahead and give acetaminophen, right? Or if it's an 8, I'm going to go ahead and give morphine. So we try to build these in a lot of cases to try to utilize these stepwise approach to mitigate how much opioids you have to give these patients, right? Make sense? Okay. Anyway, again, not everyone has to start on the bottom. People can start at the top if they need to, again, for very obvious pain issues, displaced fracture, appendicitis, all these different things. They can start higher if they need to. It's no problem. Okay, so again, looking at the inflammation, again, some of the meds we're going to use here are going to be focused on dealing with the inflammation associated with the pain, not necessarily dealing with the opioid receptors. So we're going to focus on those first, and then we'll get to the opioids afterwards. So we've covered these pretty much ad nauseum at this point, but we have a lot of inflammatory cytokines that get produced during a pain issue, during a trauma, anything like that. A lot of serotonin, histamine, bradykinin release, but you see a lot of prostaglandins being formed here. And so which main drugs do we use to deal with the prostaglandins? NSAIDs, right? Because they inhibit which enzyme? COX enzyme, right? They inhibit COX-1 and COX-2, typically with the non-selective agents there. And again, they're dealing with that whole inflammatory cascade. If you can interrupt it kind of the higher levels there after the arachidonic acid is formed, that's going to be beneficial in kind of interrupting this process here. So again, I'm not going to go in too much depth here because we've covered this already. We've talked about rheumatoid arthritis. Again, usually include these slides just in case we haven't really talked about it, depending on the order of things. So they usually get mixed up from year to year. Anywho, the other big thing to note are these pathways through the spinal cord. This is where the majority of your opioid receptors are going to be living as well, right? So again, you can have the nerves being sensitized by things like serotonin, histamine, and whatnot, and those will send those painful signals up through the spinal cord and into the brain. And so you're going to have a lot of opioid receptors are going to be lying here within the spinal cord. You're going to have some opioid receptors up here as well, but predominantly, if we can affect the pain issues here by dealing with the inflammation, that's going to decrease the amount of pain signaling being sent up to the brain. Anyone know any other ways I could interrupt this signal up to the spinal cord? Maybe. I don't know. I don't deal with TENS units a whole lot. Medication-wise, though. Yeah, block. How would I block it? Yeah, so local anesthetics are going to be really big here as well. So you can actually block these signals. Because again, how are these signals being propagated at the neuron? Those little sodium channels kind of bounce between the different the nodes there. So again, they're propagating that signal up through to the spinal cord. If I can interrupt that with something like a lidocaine or bupivacaine, we'll talk about those as well. But that can actually interrupt that signal. And so this is a really big thing, especially in the post-op setting, of how we can lower the amount of opioids that people need by using these blocks. And so if I can just inject a drug locally at the tissue to block that area, so it's basically numb because they're getting no sensation, no signals being sent there. That can be really beneficial to because if they don't feel the pain, then they're not experiencing it. You don't have to give an opioid for that. So again, we can deal with the inflammation, we can deal with the nerve actual transmission, and then we can also deal with the opioid receptors here within the actual spinal cord. Those are kind of the big areas we're going to be focusing on this pain management, and where a lot of our drugs are going to be working at. Where do you think the NSAIDs will be working? Mainly right here in the tissue, right? Because this is where the actual inflammation. So this is after an incision, or if you had a fracture, or whatever happens to be, wherever the tissue damage is, this is where the inflammation is happening. That's where your NSAIDs are going to be primarily working, right? So if you had to compare, like say after an injury, the efficacy for pain management between like acetaminophen and ibuprofen, how do you think it would compare? Ibuprofen probably would be a little bit better because it's actually doing that inflammation. Tylenol, as we know, doesn't really do that. It's going to be working a little bit more centrally. So typically, you're going to get more bang for your buck out of injuries like this with something like an NSAID. Okay, so kind of keep these kind of things in mind when we're trying to decide what medications are going to be best for our patients, right? So again, with our anti-inflammatory activity, we can inhibit prostaglandin and leukotriene formation. That's going to be very helpful for this. It helps to block some of those permeability changes and a lot of that fluid kind of build up there, the edema and kind of flushing you get those sites. And it help to mitigate that leukocyte migration, which will also be beneficial. So prostaglandins themselves are going to sensitize those pain fibers as well, so they're more likely to send those pain signals. So again, another place where our NSAIDs will be very useful if they can prevent the prostaglandins from actually being formed. And so you're going to see that these are going to be better for mild to moderate pain, right? Because again, if it's severe enough, you can still have a lot of sensitization there. Those pain signals are still going to be sent, and that's where things are going to be working, say, like more in the spinal cord, are going to be beneficial to prevent that signal from getting transmitted finally up to the brain. So this is where like our opioids would be better for more moderate, severe pain. But things like NSAIDs, they're going to be good for mild to moderate. So talking about cyclooxygenase, again, we can have agents that are going to be COX-1 selective, right? Or I'm sorry, COX-2 selective, I should say, and because that is the inducible form. This is the one that gets upregulated when you have, an injury or any degree of inflammation. Normally, we have COX-1 around. That's our constitutive one, which constitutive just means it's around all the time, right? Our body's always producing that versus the COX-2 is inducible, which means it only gets upregulated when it's really needed. And so again, this is where we're going to see a lot of the GI issues that come up, is because if we have non-selective NSAIDs blocking COX-1, that's going to help to diminish that gastric barrier that we rely on to prevent ulcers from forming. So again, we'll talk about selectivity of our NSAIDs a little bit later on, just a few minutes here. So basically, looking at the kind of etiology-based treatment here, we're going to see that for more somatic, visceral pain, this is where we're going to get most of our benefit out of things like NSAIDs, acetaminophen. Corticosteroids can also be useful here as well, because again, we saw with certain conditions you may utilize corticosteroids as a form of pain management. Which makes sense based on that inflammation pathway we were talking about. And then opioids are going to be kind of a plus or minus here, more for the moderate severe pain. On the other hand, when we're dealing with neuropathic pain, this is where things like antidepressants, anticonvulsants are going to be utilized. And we haven't mentioned baclofen yet. Anyone know what type of drug that is? It's a muscle relaxer, so you can use something like muscle relaxers as well here that can be beneficial. So again, the modality is going to be very different on which medication you're selecting based on the type of pain you have. Again, opioids can sometimes be used here as well, but we like to rely on some of these adjuvant meds first for a lot of that. So anyway, keep in mind, in managing pain, try to focus on both pharmacologic and non-pharmacologic, right? You need to focus on things like getting their PT done and things like that. And again, if you have chronic pain, do you want to do physical therapy? No, it hurts. It's a lot of work. I don't want to do that. You need to make sure they're doing that as well because it's only going to be beneficial to them. Typically, chronic pain requires a multimodal approach. So you need to incorporate, things like behavioral issues, because usually there's a lot of, depression can be a concomitant issue for all these patients. PTSD, especially if it was related back to an injury or something like that. So think about those behavioral issues. And ideally, we'd like to be able to prevent pain if we can, try to reduce pain, and eliminate it. Are we always able to eliminate the pain though? Yeah, so for some patients, you're going to have to realize this. You may not be able to completely get rid of their pain ever. You need to make sure the goals are set between you and the patient to say, okay, well, what's your goals here? Even if I can get you down from, say, an 8 at baseline down to a 4, that's a pretty big improvement for a lot of patients. That may be acceptable to them. But it's important to let them know you may never be completely pain-free. This is just something you're going to have to deal with, right? But we can try to get it managed as best we can and try to get down as low as possible, okay? But the other thing to really focus on is making sure they're retaining their functional capacity and try to either regain or retain that independence that they have. So again, this is where a lot of your non-pharmacologic physical therapy, things like that are going to be very useful here. So again, patients' therapy is going to have to be really individualized. So based on the type of pain they're dealing with, the severity, their history, if they have like substance abuse in their past or anything like that. Comorbid conditions are going to be really important here, so watch out for that. And then just realize that everyone's going to respond a little bit differently. Everyone has a little bit different isoenzyme of COX. Everyone has a little bit different opioid receptors. So not everyone's going to respond to the drugs the same way. Again, there's interpatient variability. They need to switch the drugs up a little bit. So we'll talk about those a little bit later on. And again, just because one therapy is unsuccessful, try switching over to something else can still work for them. So for instance, I know a lot of people who do really poorly with hydrocodone, they get very, very sick and nauseous, and so it's not a good drug for them. So something like fentanyl, Dilaudid is a better option for them because they don't get the same kind of reaction. So those are things we'll have to keep in mind and we'll look at when we get into the specific drugs probably next time. So any questions so far? I think it's a good place to cut it off. I guess I'll see you guys tomorrow. I think I talked to you guys tomorrow. All right, then we'll get into the nitty gritty of the opioids and other pain management drugs. Thanks.